We're here to talk about
Burnout.
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 burnout. Burnout. It's a word we hear constantly in medicine, but it doesn't look the same in every specialty. In this series, we bring together physicians from across medicine to talk about what burnout really looks like in their field. This is Burnout by Specialty. Welcome to the Burnout by Specialty series. This is a pediatrics episode, and thank you to doctors on social media for hosting this today. My name is Mary Ramon. I'm a licensed counselor and coach for physicians, and today I'm really excited to introduce to you Dr. Claudia Amami, Dr. Ben Ranking, and Dr. Crystal Revi. Let's start with brief introductions. Dr. Amami, welcome.
Hey there. This is Claudia Mami. I'm a pediatric surgeon, been in practice for over a decade plus, and currently I'm an administrator as a chief medical officer.
Welcome. Thank you, Dr. Ranking.
I am Ben Ranking. I'm a pediatric cardiologist in an academic practice setting and founder of the Developing Doctor, which is a coaching service for physicians and healthcare providers.
Great to have you here. Welcome, Dr. Revi.
Hi, I'm Crystal Revi. I was in academic general pediatrics. I now have a non-clinical career, and I also coach neurodiverse physicians.
Wonderful. Well, thank you so much for being here today. I'm going to call on each of you with questions, and starting with you, Dr. Amami. This is really about burnout specific to pediatrics. So could you describe what does burnout look like in pediatrics?
Well, I think in my case, because pediatric surgeon is technically a subspecialty, right? It's a procedural subspecialty of pediatrics. I mean, the way I would describe it, the way it meant to me. And I think it started when I realized I'm not looking forward to my consults or my operations anymore. And I was dreading the call. It was almost, it took me back to my residency years when I was like a junior resident, and I just dreaded to be on call. I dreaded going to work, and I started getting a similar feeling. And, especially when you're a pediatric surgeon, you're dealing with people's children. You always want to be your best self when you're on and when you're taking care of other people's kids. So I think from a conscious perspective, I felt like, well, it's not right if I'm not 100% committed, 100% there. And that's when I started to look into why I felt the way I felt. And to me, I mean, that was the beginning of the burnout.
Thank you so much for being open and sharing that. I know many people can relate. Dr. Ranking, what is it about pediatrics specifically that makes burnout different from other specialties?
Gosh, I think all physicians are service oriented, but I think there's definitely a servant heart in pediatrics where, we enter this recognizing that we're caring for a vulnerable population. And at the end of the day, all pediatric subspecialties are about potential and wanting this little person who's in front of us to realize whatever their God-given potential is. I think I resonate with what Dr. Amami said, sort of the disconnect from, why we went into this specialty or this field, and then all of a sudden not wanting to do that and losing kind of that joy that we had in providing this service. I think it is a little bit unique to pediatrics, although I suspect spans all the specialties.
Thank you. It is a theme that I'm hearing across specialties, but definitely pediatrics has its unique challenges. Dr. Revi, what would you say from when you were practicing, what part of the job would you say was most draining?
The part of the job that was most draining was something that I didn't even realize existed until it was gone. And that is the weight of patient care. The weight of you feel responsible for your patient's outcome, even if it really isn't that responsibility. Is that child going to drink? Is the antibiotic going to work? Will they, will they respond to the treatment or not? And I think and if their lab results don't come back reassuring, can you get in touch with that family so that they can come back, go to the emergency room, whatever? Those worries they stayed with me all the time until I was no longer in clinical practice. I didn't realize how heavily those worries weighed on me.
That's a lot to carry. I can only imagine. Thank you. Dr. Amami, as a pediatric surgeon, what do you think people outside of pediatrics don't see?
I mean, again, I think Dr. Rankin kind of referred to it. It's not that the adult world or the adult procedural world is not apprehensive about the outcomes, or especially for surgeons about the complications or what can go wrong. I think pediatrics is just another extra layer of burden to kind of point out what Dr. Rivi was mentioning. I mean, you're never really disconnected. It's somebody's child, and you need to know what the outcomes were. I mean, for me, even when I wasn't on call, I was in a two-partner practice. You are never free, of the outcomes of the last operations you did. You're always responsible. And I think in my case, I was extremely lucky that while I was heavily practicing, I didn't have to deal with a really serious complication or a really bad outcome other than just the usual and the customary. But I've had friends and I've seen friends who've been devastated by a result of something that went wrong during an operation, which happens, so if you're a busy surgeon. I mean, that's something that you can't really, you can't run away from. But I don't think that you really feel it. You feel that burden as much as you do until you get into practice. I mean, in my case, once I became a mother, that became even more of an issue, because every kid could be my kid. And, so it's almost, just to put it in a layman terms, like I never wanted to break somebody's kid. And I knew that I can't control it. And you constantly have to keep that beast at bay so that you remain the confident surgeon that you are. But you know that it's around the corner and it can happen to best of us. So that, compiled with years and years of just doing it over and over again, it adds up. I mean, for me, in retrospect, I think I never really realized how much burden I carried until I kind of stepped away and decreased it. And then I was able to take a breath and just relax, like genuinely relax, because, I was a few months away from my last operation, knowing that, okay, nothing really bad happened. But yeah, I mean, that's the way, I would say that went down.
I hear similar themes from other pediatricians who are parents, and I hear both you and Dr. Revi saying that you didn't know how much you were carrying until you stopped carrying it. So that's a theme. Thank you for sharing. Dr. Ranking, back to you. Think about system pressures. Where do system pressures hit hardest in pediatrics?
Gosh, I think this is a timely question. I'm a new division director, and so I'm confronted with system pressures that I was less aware of until recently.
We'll be right back. Check out our article called Why I Don't Take Health Insurance in My Practice or Carry It Personally while this advertisement plays on. You can find it in our SoMeDocs magazine.
The right opportunities often begin with a simple search. The SoMeDocs Expert Directory helps physicians and health professionals showcase their expertise in an organized SEO-optimized platform designed to elevate voices beyond the white coat. Check us out at doctorsonsocialmedia.com, build yourself a profile, and start getting involved today.
We're back. And don't forget to check out the first episode of our series From Print to Pod. It's in its second season and better than ever.
Gosh, I think this is a timely question. I'm a new division director, and so I'm confronted with system pressures that I was less aware of until recently. And so I think one of the things that keeps popping up is just lack of autonomy and lack of control. And I happen to have a lot of new, wonderful, great young faculty who have young families, and all of them are in two physician families, actually. And so there's this double pressure in the entire family to kind of meet the needs of the family, as well as meet clinical obligations and just career dreams and aspirations. And we have this ridiculous rule that all clinics need to run from 8 to noon and 1 to 5. And, people can't take a half hour off to pick up their child. And if they need to, right, then that's a deficiency. And so, allowing people to have just, the ability to control their schedule. I don't have anyone on my team that doesn't want to work. They want to work and take care of their families, and allowing people to do that in a way that is safe and healthy and fulfilling for them is something that could be done easily and is a pressure that could be easily relieved if uh, we were able to do that.
Such an important point. Dr. Ravi, when you were practicing, what part of it felt most unsustainable to you?
I mean, I think that the continuing ramp up, it was twofold. Especially as, it seemed like every year Bright Futures was recommending 5 new things that should be covered within a well child visit. And because of, similar to the previous question, because of system pressure and expectations, there's there was less and less time being allotted to those visits. So the sort of the shrinking of time that you could spend with your patient, there's a lot and more the expanding of what was expected the general to be covered pediatrician to during those times. And I think yet they have also less time. What has happened, especially over the last 5 years, I haven't been in practice in the last 5 years, but I'm still active and board certified, and I know what's happening within the pediatric population, especially around mental health. And
I'm hearing that. And so thank you. Dr. Amami, what is it that you think keeps people practicing?
I mean, I would like to really believe is the love of the practice is the, the reason why we all A became doctors and B decided to take care of little ones, because it's so much more pleasurable to be close to this end of life than the other end of life. Um, but I really do hope and wish more and more than that's the case. But there are generational differences, there are training differences, and people want to have work life balance. I mean, it's a good thing. I don't think it's a bad thing. But kind of alluding back to some of the comments about the system issues, the world of practice of medicine, especially when it comes to pediatrics, is changing because the hospital management, the health system managements are changing. There's a lot of mergers. They're getting bigger and bigger. They're becoming more closer to the way the corporate world runs. I worked for a for-profit system as an administrator, and now I'm moving to a nonprofit. And, there's a lot of productivity marker challenges and numbers that the administrators have to meet in order to be able to keep the doors open. I mean, it's not always malicious, but the other end of it is also more and more the people that are managing healthcare and are dictating these productivity numbers are non-physicians. And one of the reasons I wanted to become an administrator was because I really do believe that healthcare needs to be run by subject matter experts who are providers, physicians, and nurses, and not other type of administrators. Now, that's not reasonable because we all go into medicine to practice medicine, not to manage hospitals. However, I think that crossover is key. And to kind of allude back to what Dr. Ribai said, they keep adding to that plate because again, those people are trying to maximize from a productive standpoint what they can get out of an hour of a visit, to meet the bottom line. And especially now in this environment, I don't want to go on a tangential discussion about private equity and all the other forces that are purchasing medical practices, but it's going the healthcare system is going that direction, and the people that are keeping the healthcare system alive, i.e., doctors and nurses, they're more and more losing control. So that's going to lead to more burnout. There is more burnout. Like we know for a fact it's increased. COVID didn't help, but I suspect that it would have been this bad, maybe not as bad. COVID probably push started, but it was already happening. So
Thank you for that. Along those lines, Dr. Ranking, in your new role, What do you wish leadership understood, or what do pediatricians wish leadership understood?
I think maybe I'll have a two-sided answer to that. So I wish that I think administration understood that physicians want to work, healthcare providers want to work. It's not that there's a pushback for having productivity metrics and for sort of making the bottom line profitable. I mean, we all want that to happen. And what I have learned in my new role is that administrators want providers to be successful, and this relationships works best when we work as a team rather than against each other. And so I think that's what I hope would be able to happen. Obviously, that's a little bit of a rosy-colored glasses outlook, but I think that's how the system would work best.
Thank you. Dr. Riva, back to you. If one thing changed, what would reduce burnout the most in pediatrics?
I think it's similar to what Dr. Ranking was talking about, and that is to allow not just pediatricians, but physicians more autonomy and flexibility around their schedule. Most of us that go into medicine are hard workers. We want to work, but also we want to, and especially pediatricians who love children, most of us have children, and we want to care for our own children.
We're going to take a break. Don't forget to check out our swag partner at givethemswag.com. We've got unique merch we create for social campaigns, articles, conferences, and physician practices that are sold in limited runs and are therefore a few of a kind. Make a statement, start conversations.
We're so much more than articles in a magazine. We're networking, we're conferences, we're learning, we're growing, we're providing publicity for healthcare professionals today. Membership now free for US-based healthcare professionals. Go to doctorsonsocialmedia.com.
Did you miss our show? We're now back.
Most of us that go into medicine are hard workers. We want to work, but also we want to, and especially pediatricians who love children, most of us have children, and we want to care for our own children. And to allow us to have flexibility in our schedules so that we can be the care providers for our children would I think would go a long way towards helping burnout.
Thank you. Dr. Amami, any advice for doctors going into pediatrics?
I mean, I would say get informed about the ways of the world and how the world is changing. Information is power. I mean, it's great to have rose color glasses and to be idealistic, but if there's a big gap between the idealism of what you think it's going to be and then what it ends up being when you arrive, I think that disappointment because of unmet expectations is going to lead to immediate burnout, or it's going to set you up for failure. I mean, at least if you go in full knowledge of all of what it looks like and what you're going to get into. I mean, hopefully you will be pleasantly surprised, but a lot of times I think people end up getting disappointed because what they expected is not what it turns out to be.
So I have one final question. It's the same question for each of you. How can we make pediatrics more sustainable?
Yeah, I think it goes back to providing some local control. So having some broad expectations, but allowing local control for people to control their schedules or their templates, or empower sort of the middle management a little bit to be able to allow their teams to function as efficiently as possible.
I think, and this may not be a popular opinion, but people please write in. Let us know if you don't agree. Separating the people who take care of like the bread and butter well childs from those that are really taking care of the higher acuity, more complex issue. That may be in the form of nurse practitioners or physician's assistants and using those more, but then also keeping pediatrics, it's almost like a European or an English system where the higher acuity, the more complex patients are taken care of by the experts in the field, and the routine. I mean, I love well child checks. I do. And I love watching those kids grow. but also, is that the highest use of my license? I don't know.
I mean, it's a little unfair for me as a pediatric surgeon to kind of comment on the field of pediatrics as a whole. But I do agree that there is a difference between pediatric hospitalists that take care of high acuity pediatrics cases in busy hospitals, whether it's a freestanding children's or a children's within a bigger hospital, or in rural communities where they take care of everything, versus an outpatient pediatrician, and what they do and what they're involved in, with well child visits and vaccination. Ideally, I think this is the field of pediatrics needs to be compensated a bit better. I think those productivity pressures will ease up. One of the reasons that you see that, and at least in a hospital setting or acute setting, is just because of reimbursement of what a pediatric unit brings back versus what a neonatal unit brings back. I mean, that's, again, I don't want to go off on that tangent. But speaking to middle management, yes, I do agree that middle management needs to provide a little bit more autonomy to pediatric providers. I will tell you that just based on my experience on the other side of the fence, a lot of time middle management is not aware of what pediatricians and pediatric specialties really do, even less than what you would think they think those same specialties would do for adults, because the majority of pediatric care happens within adult hospitals. We don't have that many children's hospitals. And if you're in a children's hospital working as a pediatrician or pediatrics a specialty, your life is very, very different than when you're a pediatrician in either a pediatrics hospital attached to a big one or a part of the big one. So there's a big disconnect. And there aren't enough of us involved in middle management to be able to educate that management class about what it really means to deal with pediatric population.
I'm so grateful for each of you for adding your unique voices and experience and expertise to this important conversation. Thank you so much, Dr. Amami, Dr. Rinke, and Dr. Revi. This will conclude our pediatrics episode of Burnout by Specialty. Thank you all. Burnout may be one word, but as we've heard, it's not one experience. This is Burnout by Specialty.